So, as usual, I'm very thankful for people giving up their lunch breaks to come and listen to our webinars, and I'm delighted to have Charlie Mair with me today. The West of Scotland Safe Haven Manager. Data is becoming increasingly important in research and innovation, and I don't think there's a conversation I have with anyone where they're not asking about data, different types of data. Can we bring this type of data together with that type of data? How many of those types of data's points, can we access? So I think it's going to be really great to hear from you, Charlie, about, how data is being with the Safe Haven to understand, how their research can be supported. But before we get into the technical side of data, it'd be really useful if you could just tell us, how is data organised in the NHS? What does it look like, and how does it work?
Yeah, so I think I'll kind of give a very brief overview at the start of the slides here, kind of how data, well, perhaps was collected and organised in the NHS. And then I think during the course of, well, hopefully over the next hour, I'll kind of get into the ways in which the NHS collects and organises. And then I think what we're talking about here is really trying to reuse some of that data as well. But I'll just get into my slides. But I suppose the headline for this talk, which we're talking about today, is that we're very much talking about real world data. Some people call it routine data as well, but it is NHS data that is collected and stored during regular interactions with the healthcare system. And then hopefully what I can convey today is a little bit about how we can try and reuse that data for research purposes, reuse it in a secure way, reuse it in an ethical way, and hopefully support some of the sort of exciting projects that we've been seeing here at the Living Lab and across Glasgow. So
great, thank you.
Great.
I'll hand over to you.
Thanks very much. So I'm going to start this talk way back in the mists of time. So I've got a picture on the screen here of what I would call, one of the original information storage devices for the NHS. So this is an envelope known as the Lloyd George envelope, which was really introduced way back when, pre-war, when national insurance was introduced in the UK. And these envelopes were used to store notes, medical notes about patients. I've put on here, one of the most exciting developments was, over 50 years after its introduction in 1974, which was when they introduced an A4 version of the envelope to kind of reflect it was progress. But that change is still relevant today because, it was about standardization of information, standardization of the storage, and they just moved to, the A4 standard. But I used to work in GP surgeries, have managed a GP surgery as well. And we used to get these envelopes delivered, off an NHS van in the afternoon for new patients that are being registered. So, but this is very much supposedly the old way in which data was stored in the NHS, paper records, paper envelopes. But like I'm saying, these were only resigned from the NHS in January 2021. So
my dad was a GP. And we used to work in the surgery in the summers digitizing the records, and that meant scanning everything. And that was earlier than 2021. I'm a bit older than that, but that was the move towards digitization.
But still very much the modern era. And I suppose where I'm starting this talk from is around the sense that we'll be talking about, probably some of the sort of high-tech, innovative uses of NHS data in imaging, artificial intelligence, and how the Safe Haven supports that. But really, we're in a transition period at the moment. We are still in the NHS moving from these old systems, these antiquated systems, another example of which I've just popped on the screen here. If you are working as a doctor or if you're a patient on the wards here at the Queen Elizabeth Hospital, you will still see every so often one of these records trolleys being wheeled around the hospital, doctors referring to paper notes as well. And I've put here, yes, you can still procure these. They're on the NHS suppliers website. So there's companies in the UK still manufacturing these. And again, I won't labour the point, but you know, I think the NHS is really still in this transition from being very much paper-based, paper record-based, and then trying to modernise and trying to adopt new technologies as well. And I have indicated here, at the moment, the medical records trolley has no AI integrated, but maybe that will change. Maybe that will change in the future. So, so we've started with the Lloyd George envelope in 1911. We've still got records, paper records, particularly in the hospitals. I'm just going to very briefly mention here a program that NHS England tried to introduce back when I was working at Camden Clinical Commissioning Group in London. I remember I just started with that organisation. There were lots of leaflets and posters being shared around GP surgeries about a program called care.data. And that program was intended to digitize and collect all primary care records into one system, and then to hopefully make that information available, not just for routine care, but also for research purposes. In a matter of weeks, I remember there were a number of very negative stories in newspapers that I will not mention here. And the program of work was canned, dropped very, very quickly by NHS England. It wasn't popular at that time, but I think that the data regulation laws was still developing. It was at the time that GDPR was still very, very young, very naive. And there was still an appetite, I would say, both in all four of the nations, to provide some secure, safe, and acceptable way of collecting NHS patient data, securing it, and then providing a kind of a safe way in to access that. I mean, and I will mention here, that care.data program was abandoned, but really that was a time when data science was accelerating. I mean, if you think about what's happened in the last 10 years, like you said at the start, you can't start a conversation about science, about working in health these days without the mention of the word data or something like that. And so what they decided to do in Scotland, the Scottish government proposed an alternative model. And they proposed a model which was very much like the model which was adopted in Wales as well. And in Scotland, they called this model the Safe Haven Network. And the idea was that we would create a network of a very small number of regional so-called safe havens, plus a national safe haven in Scotland, to provide a way to secure the NHS data, to link those high-value data sets that we have in Scotland, and then to provide a way for researchers, many of which are in the audience today listening to the webinar, to access that data in a safe, ethical way, with various protections and controls to make sure that the data, the people, the outputs from the research posed absolutely no risk to the privacy of the patients, which is paramount in all of this. So that brings us up to the modern day. So what we have here in Glasgow is one of the regional safe havens. So we're known as the West of Scotland Safe Haven here. And we are composed here, in the offices that we share, with yourselves here at the Living Lab. We've got a team of data managers in my team. It's not a very big team. So it's at the moment, it's only 5 data managers. We've got a couple of data analysts and a project manager and myself. and we're all employed by the Health Board as well.
Yes.
So we're all employees of the NHS. And we operate what's called a research database. So a research database is something that you can apply to an NHS ethics committee to create.
Yes, okay.
So that's what we've done, and we refreshed our permission to have that database with an ethics committee in January last year. And what we have is something called delegated ethics.
Yes.
So people can apply to us, and we have a committee, which I'll mention in a little while, who review the applications, think about whether or not the application is proportionate, of scientific merit, of benefit to patients, and things like that. And then the Safe Haven then has processes by which we can extract data from source systems here in the Health Board, de-identify that data, pseudonymize that data. So the way I try to explain it to people is, you know, if you were in one of our data sets and I gave you access to the data set,
I shouldn't know I'm there.
Yeah, you probably wouldn't even be able to find yourself without a disproportionate amount of effort. So yeah, so all of the data is de-identified in that way, but it still allows you to do statistical analyses. It allows you to evaluate patterns in the way that patients were treated, or ways in which they were attending hospital, for example. And providing the data like this also allows you to do some of the clever, whizzier things that people are very interested in these days. Things like machine learning, things like validating artificial intelligence, and we'll talk about some of those projects in a little while. And really, on the right-hand side of this diagram here, you can see the general flow at the top of data in assorted clinical systems flowing into databases that we have access to in the Safe Haven, all identifiable. But then there's a point at which, for each project, we then create a de-identified database and then provide those data sets into a suitable environment.
So I presume that means then that there isn't any one standard data project as such, and that data can be drawn from different databases, different sources, based on the needs of the researcher, assuming that it meets with the ethical committee's approvals.
It's very much the majority of our projects are essentially custom created, custom linked data sets to answer a specific research question. But we have explored other models, other ways of creating single data sets to support multiple projects. And if you want to, we can talk about that later. So I thought it would be worth just taking a couple of minutes just to explain how the data is presented to the users. And this slide here is one of the materials from a national organisation, Health Data Research UK. And they're just one of a number of organisations that have been working on developing an infrastructure and a set of processes across the 4 nations to enable access to NHS data and sensitive health data. So the model that we're using here in the UK, again, some of the audience here are probably very familiar with this, but where the data ends up is called a trusted research environment, and these are often called data safe havens as well. They are a set of people, so the users and the data managers, and processes and procedures to process the data, de-identify the data, make sure that only the data that is going to one particular project goes to that project, et cetera, et cetera. And then the TRE is also then a door into the data as well. So they talk about safe people, so everybody is trained. They talk about safe projects. They all have ethical approval. Safe settings, which is the computers and the IT that you're using to access it. Safe data, as I was talking about, de-identified. And safe outputs is when people have finished their projects, they want to put something into a publication, so checking that those outputs also pose no privacy risk.
So the data all stays in that environment that's been approved by the NHS, and people come to that environment for the period of time to deliver their project.
Exactly. It's very much a model where we host the data and invite people to come to the data, which is perhaps, to go back to that sort of model of 2013, 2014, I think what patients didn't really find acceptable was the idea that their data would be extracted and sent to external providers where you didn't know what was happening. So this is very much a model which allows us to retain control over the data, and we have all sorts of kind of audits and ways of scrutinizing how the data is being used. And it's worth mentioning, actually, until quite recently, most of the regional safe havens used to have a physical room that somebody could go
and plug into almost.
Well, you would sit down at a computer and there were, a bit like here, video cameras watching your every move. And that was, for a brief period, another way of creating the safe setting. But we now allow remote access, VPN access. So we've moved on from the kind of the panoptical locked room being studied. So but that's trusted research environments, and for people who are interested in accessing data, it's worth learning a little bit about that model and how you use it, because it's a bit different to traditional research access. So right at the start, you asked me about sort of the data, sorts of data. So what I've got here is just very quickly a kind of a run through of the typical sorts of data that are collected at the hospital here, and then which we then make available in the safe haven. So if you can imagine, I've cycled into work. It's frosty. I'm cycling too quickly. I fall off. I've broken my leg. Typical cyclist.
I did that a few years ago with my elbow.
There we go. So quite common. But you end up at A&E here at the hospital, and you are admitted in. That's the start of data being recorded. That's often called an episode of care. And it happens at a location, a date, a time, and you begin to be diagnosed. At that point, you are usually assessed by various experts, nurses and doctors, and they begin to enter data into systems here at the hospital, clinical portal, records appear on Track Care, and we begin to establish, I want to call it a paper trail, but it's not a paper trail anymore. It is an electronic trail, a digital trail of your stay at the hospital. You may have tests. So like most hospitals here, we can via X-rays or, assorted clever, radiology examinations through you. We may take samples and send them to the pathology lab to check those over. We may send samples away to the microbiology lab as well. I know that looks like a pizza on the screen there, but it is meant to be a Petri dish with bugs growing in it. And then depending on what's happened, I've broken my leg, but perhaps I've been admitted. You may then move through the hospital. You move through different beds. You move to different places. And again, Safe Haven has access to information about those movements. You will hopefully get some treatments to make you feel better. And, we've got quite detailed records here of both medicines that are prescribed in the hospital when you stay here, and then medications that you may collect from the pharmacy, around the corner from your home. And we'll also do investigations. You may be hooked up to an ECG machine, for example. And again, this is other types of data that the Safe Haven here in Glasgow has handled, and we may link for projects. Eventually you're discharged. Still in the NHS, I mean, you were mentioning, working in your father's GP surgery. You were talking about it earlier, but, the letter... Those
discharge letters,
the letter is still very much, a way of exchanging data and information in the NHS. But again, what we call them in the safe haven are unstructured records. So that's free text.
Yes, so you have to.
Letters and words. And again, we can touch on that later, but again, a number of our current projects are around using language models to
extract,
extract the information. And then there might be follow-up. You may go back to your GP. You may come back to the hospital, to a clinic later on. And again, we can access data and information about that. So what you have here is very much a kind of a summary of the sorts of data that we can access in the safe haven. We've got records going back 15 years, 20 years. As you go further back, the data begins to degrade, it's lower quality and it's got gaps in it. But every second of every day, here right now, there are people being scanned, clerked in, treated, moved around the hospital. So lots and lots of data and lots of opportunity for improvement as well in the system.
And so that older data, you can then link to recent data and outcomes and start to look for patterns that may predict how people have fared or have responded.
Yeah, no, that's a great point. And that's one of the real selling points of using real world data like this. If I was to set up a clinical study today and ask patients, how do you feel? And then ask them how they feel in 6 months' time, it's very limited, the time that you can cover. Whereas with real world studies like this, you can go much, much further back in time to the point at which 15 years ago, somebody was diagnosed with a heart condition, a liver condition, and then begin to look at those long-term outcomes. And like you say, look at predictors.
Yes.
Yeah. So just to follow on from that previous slide, the actual data that we host in the safe haven and then we make available to researchers really mirrors what was on the previous slide there. At the top here is a synthetic example of some structured data that we have in the safe haven. And each of these rows represents a different patient and a different episode of care somewhere in a kind of a made up hospital situation. But as you can see here, we've got data on hospital episodes, diagnostic codes like ICD-10, which people were probably familiar with. We have procedure codes. So I was looking this week, building a cohort of patients that have had different valve replacements, so heart surgery. But we also have data, like we mentioned, letters, clinical notes, laboratory data is a very, very big data set, prescribing data, imaging data. I need to take a breath because there's so much data here. Device data, pathology data as well, which includes slide images as well. And the great thing is it's all linked on the community health index number, all de-identified. And so you can build up quite complicated data sets about a patient journey. And
I mean, that's obviously a really comprehensive list of data. Is there any data that you can't access?
Yeah, I think the one that we always get asked about is primary care data.
Yes.
And primary care data is a little bit difficult to access here in Scotland. Our counterparts at Datalock in Edinburgh do have access to primary care data for NHS Lothian. It's fairly complicated to work with, and NHS Scotland are working on a solution to try and make that primary care data for all of Scotland available for research, but it's still very much a work in progress. And I would say of that list there as well, the other one that we do struggle to access sometimes is things like letters and clinical notes. And we have a plan in place for hopefully next year getting better access to that. We have to work with our one of our providers here in the NHS to help us get access to it. So we know where they are. We know how to access them, but that data set is so enormous that even moving small volumes about is going to be a challenge, but an interesting one all the same. So that's the sort of data that we have in the safe haven. But then I thought it would be good to sort of try and put a bit more sort of sort of colour into it. So what I've just popped up here are just a few examples of research questions for projects that we've been running.
I recognise some of these.
You will too. They were related to living lab projects. But here, just to go through these, one of these is about using data to try and do better stroke audits. They're done manually at the moment. So the hope there, that's actually a European project, working with partners across Europe to try and use unstructured data, clinical notes, to quickly populate audits for stroke. So when somebody has a stroke, you can then collect reliable information about that. We're also involved in a surveillance project, again, across Europe for children that have eaten magnets. I did not know about this, that this was a problem, that apparently, lots of toys.
There's some appeal to them.
It's just, you imagine your kid there just looking at it, thinking, I shouldn't eat this, and then they pop them in the mouth. So, so there's a surveillance program about that. We've got lots of projects, of course, in the area of oncology, across assorted different types of cancers. And Cancer Research UK in particular are very interested in early detection of cancer. So really trying to use data to spot cancers earlier. Here, there's mention of AI tools to diagnose and manage lung cancer. So that is one of the Living Lab related projects. And that one's quite interesting because it is creating what we call multimodal data sets. So taking structured data, imaging data, interesting tissue data, and really beginning to kind of create sort of novel, very unusual data sets for data science purposes. And again, here in Glasgow, we're running projects in collaboration with Public Health Scotland, looking at flu at the moment. I don't know in the audience how many people have got a cough or something like that at the moment. It's very common at the moment. Yeah, it's that time of year. But we're running a project at the moment looking at people coming into hospital that have got complicated infections, epilepsy projects. Scotland and Glasgow is a major site for the care of people with burns as well. So again, like you're saying just now, with that project, with the burns project, we can look at longer term outcomes for patients. So not just what happened to them in the first few weeks, but what happened 6 months, 12 months, a couple of years later. So very busy portfolio in the Safe Haven year. We probably do 50 or 60 projects of assorted sizes through the year. Some of the projects are quite small, they might involve just a few thousand patients. But what I've put here are some of the bigger projects. So for example, we've created a respiratory data set of everyone in Glasgow that we think has, respiratory problems. Again, Glasgow is an interesting place to do research like this. You've got a very diverse population, unfortunately a lot of health inequality, but you also have a lot of different diseases represented.
Lots of chronic diseases and multimorbidities.
And that's also sort of part of the aspiration of the Living Lab is sort of, to look at that health inequity. Some of the bigger data sets that we've created, an unscheduled care data set. So that's just over 3 years. We've built up a cohort of over 400,000 patients that have been through the doors of the various hospitals here in Glasgow. It could be for anything. It could be like a trip. It could be something very complicated. But again, that is of particular interest to the NHS. We really struggle when it's very, very busy to manage the flow of patients. So having data sets where we can begin to look for ways to triage the patients better, move patients more safely back into their homes is really, really important. Glasgow is interesting because we have a very large digital pathology collection. So that is 2 million slides and growing of your classic, everything from H&E slides
to fancy fluorescent staining.
So we've got, really amazing state-of-the-art, laboratories, some of the biggest laboratories here in Glasgow, biggest laboratories in Europe. So we are looking at ways that we can use digital pathology, again, to speed up diagnosis, to streamline services, and to really try and make reduce the time from interacting with the healthcare system to getting treatment and hopefully getting better.
When I first came to the university, the project I was involved in was the molecular pathology nodes. That then kind of the next iteration of that was iCare, as it was here in Glasgow as well, and that digitisation of the service, but then also looking at what that allows you to do in terms of research for all the purposes that you've described. So I have a bit of a personal fondness for the digital pathology.
And I did pathology at university as well. So I remember, that looking down a microscope at things. But the digital pathology area is another great example of how the NHS is trying to pivot from, in this case, little glass slides and boxes to, like I say, digital photographs of slides, and then using clever, imaging techniques to spot patterns, look for deformities, look for unusual growths on those slides. Again, I've mentioned the letters. It's just to mention that, typically at the health board, we have millions and millions of interactions during the course of the year. Most of them generate some sort of written note or some sort of letter. And I always think in my head, the amount of time that our expert clinicians are spending on writing letters.
Yes, or deciphering writing.
Indeed, handwritten notes, and trying to work those out is really disproportionate. And I really expect in the next few years that, finding better ways to record information, to record what happened when somebody stayed at hospital is really going to transform over time. And again, just to mention another kind of example of volumes, on the back of, you mentioned that iCare, which was a big imaging program here in Glasgow and across the UK. During COVID, we were using local X-rays from people coming into the hospital to train an algorithm to try and spot COVID patients. Again, it was probably the first time that things like this were done, and particularly done with basically live data being generated, day by day in the hospital. And again, Glasgow is a really unusual place because we've got interesting population, lots and lots of activity in the hospitals, lots and lots of high-tech kind of kit and equipment happening here, and the ability to link across those data sets and to work with the researchers to try and ask interesting questions of that.
I might just let you pause for breath there for a moment, Charlie, just to also ask our audience if you have any questions that you would like to ask, if you could please start sending those in.
Great, yeah. So I'll talk for maybe another 10 minutes, and then we can have a look at those questions there. I think that would be good. So I think I've added this slide in because I think it's important to try and also convey that because it is real world data, because it is NHS data, we do also have an obligation within the safe havens and within this TRE network to try and publicize what we're doing, to try and let patients know what we're doing. And we do that in various ways. I said that we have delegated ethics, and our local ethics committee has got members of the public on that.
Yes.
We also have to report, because we are a research database, we have to report to our ethics committees on what projects we've done and what outcomes there have been. We publish, or our researchers, publish in peer-reviewed journals. There are sometimes media and press stories. So this one here on the right-hand side, again, is a mention of a project that you're familiar with.
It is, yes.
Again, using, in this case, X-rays to try and spot lung cancers using AI. We do public events. We work very closely with the other regional safe havens. We collaborate with another data organisation in Scotland called Research Data Scotland. And we've also input into the sort of evolving policy and evolving discussion. We've got a new safe haven charter, which is a government document about the safe havens, which is in draft and should be reviewed in the near future. And we've also been involved in other Scottish Government initiatives like unlocking the value of public data. So again, I like to think that things have moved on from the very sort of cautious and perhaps hesitant approach that the public had around using health data probably 10 years ago to really hoping to build and continue to build that trust to use data to hopefully provide tangible benefits to the patients. And that's really important for me, is for any of our projects, that it is understandable to an ordinary member of the public what the project is, what the data is, and why it might be useful.
I imagine it's an area where you never really get time to pause for breath in terms of, how quickly everything's moving, how much data science has evolved, in recent years, the needs and such like, and, that you're constantly developing new approaches and new pathways to bring different types of data together, because it just moves at such a pace now.
It does, yeah. I think, I started at this Safe Haven in 2020, and I think prior to my arrival, a lot of the projects were very much sort of retrospective, statistics-driven projects, looking at longitudinal populations. I think it has developed now with the introduction of lots and lots of imaging projects. We've got projects using data from devices, and there's a real appetite to use unstructured data. And we haven't even begun to scratch the surface of things like, video as well, which is very, very data hungry too. But no, it has moved on, lots and lots of AI, lots of sort of new data science techniques. And it's really, a moving target now that we are trying to keep pace with the inventors, the researchers, companies, to provide the right sorts of data, not just to develop new things, but to check and test that the things they are inventing are working and are safe. So, but definitely safe havens have developed, and I think that's reflected in our operating procedures, updates that we've made to our research database ethics, updates to the Safe Haven Charter. So, yes, never a dull day.
No, I know. I live in the same building as you, so I'm aware.
So just to conclude, I mean, I'll mention some of the sort of the developments that are kind of happening over, likely to happen over the next sort of 12 months or so. And then I'll also mention about how you actually access the Safe Haven. But the Safe Havens in Scotland are part of what is now a growing network. In England, they call them secure data environments. They've received fairly hefty investment from the NHS in England to establish what are equivalents to safe havens in England. I think it's fair to say that for a while, Scotland and Wales were ahead of the curve. And now England are really kind of, catching up with what the standards are for trusted research environments and how to do data research. But we are looking to work as closely as possible with our colleagues across the 4 nations. There is the kind of context in Europe of developing AI safety law. So a lot of what we do now is data science around AI, but all of that now needs to be done in the framework and the understanding that regulations and the legal environment is maturing. Lots of policy documents coming about using data. So in Scotland, you have the data strategy for health and social care. You've had the very recent last month Sudlow review, which I'd really recommend everybody take a look at as well, because again, it is summarizing the aspiration and the intent to try and use the nation's health data
for the benefit of
because UK is really in a unique position in terms of linked data across the whole country, and I think it is really not about it being a money-making exercise. It is about us developing really, really robust new tools, processes, data-driven techniques to really, the way I think about it is free up the time of the staff, the nurses, the doctors, the radiologists, everybody else, so that they can stop spending their time writing letters.
And they can focus on
patients, which is what
yes.
they want to do. So yeah,
yes.
yeah. And you know, what next? I've posed the question there because you never know what's going to come through the door or the mailbox. You know, there's always something new. So, like I say, it's a fast-moving field, and I think that in the movement of health data, there are risks, but there are also benefits. And all the time, it is really about making sure you've got the balance between accepting that there are risks to using this data, moving this data around, but there are also big benefits to be really honest as well. So I think what we're trying to do here with Safe Havens is get that sweet spot.
Yes.
Yeah, yeah. So very quickly, people always at the end of these talks, they want to know, they're interested.
Yes,
So in terms of applying for access, usually we're kind of quite informal at the start. We like to have a call with people. We like to have a conversation about, you know, what is their research question? What's the project? Is it going to be feasible?
Yep.
Because not all projects, you know, can be done using the data that we've got. We route most inquiries just through our mailbox. It's the easiest way to get hold of us, and then we can set up meetings and begin to have a chat with you about what you need. We help people with their ethics application here. Yes. So we don't just give you the form and send you away. Yeah. But we work quite hard to kind of help you build a really, really good ethics application to our committee so that it's easy for them to understand, easy for them to pose questions, and then for you to get that ethical approval. We operate on a cost recovery model. So we're not selling data, but what we are trying to do for all the projects, most of which have, you know, some sort of grant funding is very sort of common these days, is to try and cover the cost of, like I said at the start, my data team, and then also those costs for the trusted research environment as well, which doesn't come free. No. And then once you've got approval, we initiate the project, we build your cohort, we link your data, and people always ask us, you know, how long this stuff takes, but with a fair wind behind us, you know, we can prep an application, you know, in a matter of weeks. I really appreciate the work of our ethics committee. They're really, really motivated, really, really interested. So it's often a very quick turnaround time from them. And at that point, you know, the limiting factors are really just how many projects we've got
on the books
online at any time. Because we've got quite a busy portfolio. I do let my staff take holidays sometimes as well, so they'll get a few hours off at Christmas. But but you know, we work quite hard to project manage all of these projects and get them up and running. But once the project is up and initiated, it's usually about 4 to 6 weeks to hopefully getting the data delivered into the research environment. We also offer support at that point. I think that's probably somewhere that we could probably improve in the Safe Haven. I think kind of some researchers, if it's the first time they've ever worked with real world data, you know, if you've worked with real world data, you know that you're not going to get a lovely clean.
No, there's going to be gaps.
Exactly. You know, and you're not going to get a lovely clean data dictionary, you know, describing field by field. But we're there to provide support. For some projects, we refresh the data, we add new data in. Some of the projects can go on for a very long time, so we will continue to support those. And again, my team, we help with the output checking everything that comes out. So I would say, if you're interested in working with the West of Scotland Safe Haven, you can email us here, or again, via the Living Lab. You know, we work very closely together. It's a collaboration. So that's another door you can go through to learn more about accessing NHS data. And I think at that point, I will pause.
Who've come in, so let's see how many we can get through. So I might start with one that you have just talked about, and funding routes that people, you know, apply for to support these types of projects. And one of the question has asked, you know, are there any specific funding routes that you would suggest exploring, you know, for these kinds of projects?
Yeah, I think a lot of the kind of the funding, the big blocks of funding that have come in via UKRI. So they're often collaborations between the NHS, the university, and companies. So keeping an eye on that UKRI website is often a good idea. Lots of grant funding. So I think it's fair to say that you know, some of the big grant funders, you know, probably like 5 or 10 years ago, if you'd said that you've got costs for, you know, extracting data and hosting data, they might have said, well, really, you know. But now I think grant funders are really on board with data-driven studies, data-only studies, real-world data studies, and they do accept that, you need cost recovery to cover the costs for the NHS, for the data managers, et cetera, et cetera. And sometimes, you know, smaller charities as well have also funded safe haven projects as well. There was one about sort of social interventions in A&E, and a charity that was sort of offering interventions to people that needed it. So so I would say lots of opportunities out there, and safe haven can help with providing quick turnarounds for costings and NHS costings to support your grant applications.
Do you think that data access costs are prohibitive to some of this research, or do you think that there's sufficient funding mechanisms out there to enable it? Yeah,
I think that a lot of projects can be delivered probably with fairly modest resource in terms of the actual the trusted research environment, the compute, et cetera, and I think I would predict that in the next few years that we will probably try harder to be more efficient around using standardized data sets with standardized ethics, so that we're not so that every job is not a custom extraction. That said, I think researchers definitely need to take a breath whenever they're thinking that they're going to be doing things with GPU-driven, pipelines for machine learning. Anything that's going to involve very large data volumes as well. You might look on on a website and think, oh, I can buy terabytes of storage. It's not that expensive. But when you're talking about digital pathology, imaging, training algorithms, cloud costs are becoming really, really, really expensive. And a lot of the TREs and secure data environments are now pivoting from cloud to think, well, actually, maybe we need some on-prem compute, maybe we need hybrid solutions because it's very expensive moving this data around for research. So costs aren't necessarily prohibitive, but for certainly for projects, you do need to think about where the data is going to go, and is it actually going to be computationally quite intensive? Because I've seen projects where they are costing in 6-7-figure sums to cover just the compute for very, very large data sets in the cloud.
Okay, moving on to the next question. So you talked about AI, and AI approaches. What do you think are the key technical challenges for the safe havens moving forward when you think about, AI, those very large data sets, complex workflows?
Yes, I think there's probably just 2 comments to make on that. One is a follow-on from the last answer, which is that a lot of these workflows do require a lot of fast storage. They require access to fairly shiny, nice GPUs, preferably in big, expensive arrays. And I think bringing sensitive private data close to that compute is a challenge because the NHS is set up to keep data secure and keep it within the network. And what research is asking of it is to replicate that data and bring it close to different resources. And then the other thing to bear in mind is that historically, the trusted research environments were very much locked boxes with very limited software options. You'd get some stats packages. So trying to respond to the research community, respond to the sorts of software stacks that they're asking for, is a challenge in the TREs, but it's one that we are mindful of. And particularly in Glasgow, we have tried to be flexible in terms of providing the tools that people need to do these kind of AI, ML driven routes.
Okay, we've got 2 more. So you mentioned some of the bespoke data sets that have been established here in Glasgow, and we've got someone asking, is there somewhere that they can see what all of those data sets are that exist, and how do they then start to think about applying for access to them?
Yeah, so we've got a presence on the Health Data Research UK Gateway that lists our big core data sets. And we have produced previously very, very long lists of all of the sort of smaller, more esoteric data sets that we have access to. I think my preference now, though, is really to invite people, if you're interested, if you're in a particular clinical area, come and speak to us, because there's not really any limitation on us scoping where we might get data from. So I would say over the last 6 months, we've been looking at data from sleep devices in the hospital. We've been looking at angiogram data. We've been beginning to explore things like MRI scans. We've had some successful work with surgical colleagues, so extracting data from systems for when they're assessing people before they perform surgery. So if I do have lists, if people want to contact us, we generally will provide them via email. But I think definitely come and speak to us, because if you're in a clinical area, you probably know already what the workflow is, what systems you're using. And that's what my data managers are really, really good at, is facilitating access to extractions from system and movements of data across the health board. So come and speak to us.
So you mentioned there, looking at accessing different data from different types of data, but we've got a question that's more about the geography. So you talked about England and Wales. What about Ireland? Is there a view in the future for how you might start working or linking up with data in Ireland, or does it happen already?
I think I'll confess that it's not an area that I know an awful lot about. I was speaking to somebody from the University of Galway, who we're doing a project with at the moment, and they were originally based in Glasgow. And they were saying that there is a big difference between the quality of the data, the linkage of the data, and the availability of it here in Scotland versus in Ireland as well. So, like I say, I can't really comment in detail upon it, but I think that there is a difference between the different nations. And if you have a particular research question, I would say, keep an open mind. Maybe it might be better to do that initial linkage to your data project somewhere else. So go to the data rather than, trying to get data from the NHS where they're not set up to provide the data can be very, very, very complicated and potentially quite costly. So,
Okay, so we've got one final question that's going to test my understanding of acronyms as well. So do you have EPR level data, which I'm assuming is electronic patient record level data from EHR systems, electronic health record systems, as opposed to HES style data sets? Is that, I don't know what HES means, I'm sorry.
Yeah, no, I'm not familiar either. So, maybe it's the difference between sort of audit type data set and EPR level. So we've got, so a lot of the data that we're linking in the Safe Haven is reporting data that's come out from the health board. It gets sent usually for financial planning purposes to Public Health Scotland, so that they can do calculations for how much the NHS might cost in 6 months or 12 months. So we're often working with these audit type data sets that get returned to us, which are very clean. They've all been validated, but we can also extract data from core EHR systems here at the health board. So that's systems like Track, and we can extract really, really complicated, messy, real world data from our live systems, which, for example, shows minute by minute people moving around the hospital, or lab tests being reported, et cetera, So, but I would say those are sort of, if that's what the question is asking, that those are two very sort of different types of data, and we've got both represented in the Safe Haven. And I'd say it's probably a slightly different skill set for a data scientist to work with the kind of raw source health record data coming from the core systems versus some of that cleaned, like it said, hospital episode statistic data, which is what we call our Scottish morbidity records here in Scotland. So but we've got examples of both. And I would say it's really important for us to provide both types of data, because you can develop tools, develop approaches using very clean audit statistic reporting data. But if you're ever going to create a solution to deploy into the live environment,
real world.
Exactly. And it needs to work. To go back to the whole point of this lecture here, we're talking about real world data. The real world data can be very messy, gappy, there's quality issues with it, but your tools will need to handle that safely and efficiently in the real world environment, which is part of the fun.
Well, I think all that's left for me to do now is to say thank you, Charlie, for your time today. It's clear from the questions that have come in that this has been, really interesting and really useful talk for our audience, and I'm sure that you will see inquiries coming through to the Safe Haven as well. I'd like to just thank everyone who has joined us online for this webinar, and I hope it has allowed you to start to think about how you can use data to support your own research projects. And just a reminder that our next webinar is on the 4th of February, where I'll be talking with Mark Hanna from Cadan Science Partner, and we'll be talking a bit more about the new Health Innovation Hub, so the new commercial space that we have just across the road from the hospital, and how that will allow companies and innovators to kind of access this environment and ecosystem that we've been talking about to support their research and innovation activities. It is December, so I can also now say have a great, festive holiday period as well. And thank you very much, everyone, for joining me once again.